to start off with, I thought it would be good for those who've not been to one of these before to tell you perhaps for the first time what an inaugural lecture is. And this is the Coventry University definition of an inaugural lecture. So I just wanted to highlight here actually that it talks about an opportunity to share that professors have to share their achievements. And I want to turn this on its head slightly. And I'd just like to say that really these achievements are shared, but they're not because of how great I am, but they're because of how great others are and how great others have been through my journey. So really this lecture is to honour all those who've taught me, supported me and provided me with opportunities to get to where I am today. And as well as those who continue to make my work a real pleasure through their dedication, hard work and belief in my leadership. So as tradition, we have to actually, I'm just going to ask the events team a question. I can't see my notes page because I've got everybody's pictures down. Is there a way I can change that? Oh, it's all right, I've done it. Hi, thumbnail picture. It's okay, done it. That's okay, good, great. Okay, sorry. So yeah, as tradition would have it, we need to start off with a childhood photo. So you can probably spot which one is me. I'm wearing that flowery floral number, and that is when I was about 3, I think. And I was born to mum and dad. There's a picture of them there, and they were missionaries. And dad was a church minister in Spain. And then dad pastored a church in London, in Notting Hill. But actually Notting Hill was a lot less glamorous then than it is now. But nonetheless, I grew up in London. And I don't know if anybody's watched the Alex Rider TV series, but if you have, you'll have seen where I went to school. And not the school for delinquents, I must add, but this school here, that is my school. So that's my claim to fame. Okay, I enjoyed school. That's a rather bad picture of me as a teenager, but I did enjoy school. I loved to study. I loved to solve problems and work out an answer. And it didn't matter what these problems were, whether they were kind of mathematical or philosophical. But I think that kind of thinking is where my academic path began. And also with teachers believing in me and telling my parents that I could do anything I wanted. But at the same time, my teachers did kind of push me into sciences for my own good. So I then had to make a career choice. And I wanted something that was intellectually stimulating. I also wanted something that was personally important. And I did have food intolerances as a child. So food and health were of great interest to me. I wanted to do something that was caring and helpful. And then, so I ended up doing a degree in nutrition and became a registered dietitian. And there's just some pictures of a typical day's work, I guess, of a dietitian. So if I was to kind of summarize my life in a Prisma flowchart, for those of you who do systematic reviews, you will know what I'm talking about. It would be a flow diagram through my career showing where significant events and people shaped my life. So I went to the University of Surrey, that's where I did my degree, and I did my training at Hammersmith Hospital, my clinical training. And incidentally, that was right next door to my old school. But it was during this time that really it was my parents and siblings, friends, teachers and lecturers and the church that all played an important role in shaping me. So I then began working as a dietitian in the NHS and later ran my own nutrition and dietetic consultancy. And over these years, I experienced really the ups and downs of life. So I got married. There's a marriage picture for you. And I had children, and these are my two amazing adult daughters now. And we also had Emily, who was a stillborn baby. And I wrote this book about Emily to help others going through similar situations. It's just really a personal story, but that's kind of one of the things that I did during that time. And I think it's fair to say as well that as a family, we also struggle quite a bit with our mental health. And why am I saying all this? Well, all these experiences, kind of from, I guess, the university of life, if you like, they have shaped and formed me from a personal perspective. They've strengthened my faith in God. They've made me more empathetic to others, and they've motivated me to move forward. So they do all form part of this journey. And then from a professional point of view as well, when I was working clinically, I did see that more clearly that often clinically we fail to see the whole person. And I'm really pleased Richard mentioned that thing about addiction, because it is all about the whole person, although there is biochemical aspects to it as well. But sometimes we do just focus solely on the biomedical needs. And that is really what I saw was missing in a lot of our practice. So what do I mean by that? Well, when you're perhaps treating someone for one physical condition, we can really all too often ignore the impact that this treatment has on another physical condition or on other aspects of a person's life, whether it's their mental health or their quality of life. You know, focusing on correcting a physical or biological problem is an embedded way to treat illness, and that is known as the biomedical model. And sometimes that is all that is needed. But perhaps more often than we think, we need to look at things more holistically. And so I wanted to look at what was the evidence around holistic person-centered care. And to explore this, I went to the University of Birmingham and undertook a PhD in behavioural medicine. So just as a sort of an illustration of sort of two things that kind of can work in opposite directions really in terms of health. So my PhD focused on these two global health problems, stopping smoking and weight gain. And I'm sure you're familiar with the conundrum that the first, stopping smoking, often results in the second, which is weight gain. And there are biological reasons for this, to do with metabolic rate, to do with appetite control, but they do not explain the amount of weight that people gain in its entirety. And so just knowing about the biological reasons isn't really enough for us to change behaviour. And just the point is really that knowledge is alone is often not enough. And I think we could all agree with that in terms of if it was enough, then we would probably have a world without tobacco addiction and without obesity. So my PhD taught me how to do health research. It taught me to integrate different disciplines to solve a problem and gave me a thorough understanding of psychology, addiction medicine, and behaviour change to add to my nutritional background. And so my work became much more embedded in the biopsychosocial model of health, which was first talked about by Engel in 1977. So this is where it's not only the biomedical factors, but also the psychological and social aspects of health and of treatment that are needed for us to reach a state of health, of good health. So I've just put up there that this was my first publication during my PhD. And for the first time, we showed in this that there was a J-shaped association between your weight or your BMI at the time that you stopped smoking, and the amount of weight you gained 8 years afterwards. And this kind of contrasted quite dramatically with a slow trajectory of weight loss if somebody continued to smoke. Now, the impact of this in terms of what it means for health is still really quite hotly debated. But perhaps the most dangerous thing and the most dangerous impact is that if this weight gain would actually prevent people from stopping smoking in the first place. So my PhD went on to explore what could we do about preventing this weight gain. But before I go any further, I would just like to give some recognition to some others. So this here is Professor Paul Aveyard, and it was his outstanding teaching in health research methods during my PhD, and also his generous investment in establishing my early academic career as a postdoc, helping me get grants and write papers is, largely down to Paul, and I am kind of forever grateful for that. And then if, I've just got a link here, if I click on this link, let's just see if it comes up in the right place. Yep, so this is just a list of some publications around that time. But what I wanted you to notice really is that these publications aren't just me, it's all teamwork, and each of these papers are produced by a team of people who did generously include me. So and that's the way of academia, very much team working. So in terms of the team that I was working with, I just want to give a bit of a shout out to them, and a shout out to the great group of friends that I worked with around that time, and also some of the fun that we had. This here next to me is Dr. Nicola Linson, and she did her PhD alongside me, and we had great fun together. And this is Dr. Amanda Lewis, when we were both superheroes. So we had good fun there. And then in this last picture, also at the front, there's Dr. Rachna Beg and Dr. Amanda Farley, who are also part of the great group that we had. And I've actually not included the most embarrassing pictures to save everyone's blushes, but I do have them and they are not deleted. So beware for another time. So I would now like to tell you of two papers in particular. So this is coming back really to how can we prevent weight gain during smoking cessation. And we did a Cochrane review at the time, and this was led by Dr. Amanda Farley, who was in the previous picture. And this was looking at, what interventions help prevent weight gain when people give up smoking. And this did shape clinical guidelines, and I'll explain a little bit more. So I'm just going to really focus on the aspects from a dietary perspective. What this found was that educational advice on healthy eating and behaviour change was actually, during a quit attempt, was actually not effective. And you can see there, very small amount, which wasn't significant, not effective at preventing weight gain at 12 months. And perhaps more worryingly, it actually reduced the chances of quitting. And this, incidentally, was what a lot of stop smoking advisors were doing at the time, or recommending at the time. So it was quite important to kind of encourage stop smoking advisors to be cautious about giving advice that might actually hinder a quit attempt. And probably the most promising approach dietary-wise at the time was this individually tailored support. And this did prevent about half the amount of weight gain at the end of 12 months. And it did potentially could be seen there as reducing chances of quitting, but not to the same extent, and not statistically to the same level of significance as the other. So not a perfect solution, but something that was perhaps an option that people could be directed to if they were very keen to do something about their weight, because it would prevent them stopping smoking. So that's just one example of a paper during that time. And this Cochrane review is actually undergoing an update. So there's going to be new things coming, so look out for that. And then the second paper I'd like to tell you about is this one here, which I'm personally very pleased with. And this is because I took it from an idea to applying for and winning the funding to do the research, to then leading a team to conduct the work. And all of that then resulted in publication in the Lancet journals. And this again helped to shape clinical practice at the time. And what we found in this study was that there was a small deterioration in glycemic control in those with diabetes at the time they quit smoking. And you can see that there's just a small increase, this blip in HbA1c. And when that was compared to the those who continued to smoke, there was no such blip, as you can see on that graph there. So what we didn't want to do was end up with a negative headline that kind of misconstrued these findings. So we were quite careful with how it was reported on in the press, because it definitely wasn't something to say, well, actually, if you have diabetes, then it's not a good idea to stop smoking. It absolutely is a good idea to stop smoking. But what this offered was that, with the kind of understanding that blood glucose could perhaps deteriorate a little bit during the time, it offered patients that reassurance that this kind of blip and this change in blood glucose was kind of a normal thing. And it also created an opportunity for them to tighten up on control at that time. And since then, further work has gone on in this area, and a systematic review and meta-analysis of further studies that then looked into this also have shown there hasn't been a huge change in HbA1c to be of great concern. But sometimes we have to think of things from an individual point of view. And at the time, if you went on to diabetes forums, you could see that people were saying, I gave up smoking, but my blood glucose has gone up, and I wish I hadn't given up smoking. And so sometimes people just need that extra information to be able to be reassured to do what's best for their health. I then decided, after doing these things, to broaden my work further and spread my wings. I was still doing some clinical work and noting that something was still missing from the way we support patients. And of particular concern to me were patients who struggle and have struggled lifelong with their body weight. And many claim that they have an addiction to food, although actually the technical addiction to food isn't kind of recognized, but that's what they feel that they have. And they also felt that they needed some more help than what was being given, and they wanted to have the opportunity as well to draw on a higher power, for example, and that kind of incorporation of something spiritual was of great interest to me. So I then started looking into that a bit more, and I discovered that there was a whole field of research in the area of religion, spirituality and health, which was coming out of the USA. And it was this man, Professor Harold Koenig, and he has been leading the field for several decades, really. Much of the work has been done in psychiatry, in mental health and addiction. But Harold offered training on the application of the robust clinical research methods, the ones that I had been taught during my PhD, to the field of religion, spirituality and health. And he, like I say, he did some training. So I attended the European Conference in Religion, Spirituality and Health and its pre-conference workshop, which was run by Harold, to kind of learn what I needed to about this. And there's a picture there of just at that European conference, those others who were with me attending that. So I returned to the UK really with a fresh vision to conduct research which integrated spiritual care into clinical practice. And for me in particular, I saw a niche opportunity to explore this within the holistic care of nutrition and dietary related diseases and problems. And that allowed me to really bring back all I had learned over the years back into dietetics. So I then took up a senior lecturer position here at Coventry University within the Faculty of Health and Life Sciences. And my role was both to extend my research of holistic care within dietetics and also to train up the next generation of dietitians and train them really to embrace holistic care in their clinical practice as well. And within the Faculty of Health and Life Sciences, I had great opportunities for innovation and leadership given to me, and my career developed. And I had wonderful colleagues, and Dr. Anne Kofopoulos deserves a shout out at this point. She was a particular, and still is a particular special friend who supported and encouraged me on this journey. And we were very pleased and celebrated when I was conferred the title Reader in Nutrition, Dietetics and Spiritual Health. Kind of by this time, the biopsychosocial-spiritual model of health. And it wasn't a new concept, and it has been written about previously by Selma Say in 2002, but it very much was often used in the care of the dying. And also by others for specific problems like chronic pain. And it was considered much less used in everyday health. And I like to consider this model with, instead of health in the middle, having person-centered healthcare right at the center of this. And I think this is really important because putting the person right in the middle here allows care to be around their own needs and their own preferences, and support can be drawn from each of those domains in different proportions depending on what the need is of the patient at the time. And the other reason I think it's very important to point out the individual, particularly with things like religion and spirituality, it has to all be about the patient. It can't be about the clinician, because it's not about coercing individuals who are likely to be in a state of vulnerability. It's not about coercing them to change their beliefs to that of the clinician. That would obviously be, unethical and an inappropriate use of power dynamics. But it is instead about recognizing the evidence-based role that religion and spirituality plays in health, and seeing whether this is important to an individual at that time. And there is a large body of evidence around the effects of positive religious coping for some people with their religious or spiritual beliefs being a great source of a great resource in times of difficulty. And it might be helpful to encourage people to tap into that. And then for others, it might actually be the effect of negative religious coping or a spiritual struggle. Perhaps they have had a poor experience of religion or religious institutions, and they might carry, say, an unhealthy sense of guilt. Perhaps they are in turmoil because what they believe and the circumstances they find themselves in appear in conflict. And all of these things can take their toll on health, and both physical and mental health. And I'm just going to show you here, this is the kind of pathway by which that works. So this is the psychoneuroimmunological pathway. And you can see there that, whether people are having positive religious coping or negative religious coping, that positive religious coping in general sort of reduces stress. That tends to be the way that it works, whereas negative religious coping increases it. So there's a psychological response, and then a psychological response leads to a physiological response and immunological one. So we have involvement of the nervous system, of the immune system, of the endocrine system, and that's how it all translates into physical symptoms and disease. So if you go back along that pathway, you can see that religious coping has a potential to affect physical disease. So my influence of using this model within certainly the profession of dietetics was perhaps best summed up in an article that I actually read quite recently, which looked at how to integrate spiritual care into the nutrition and dietetic process. And this was to enable identification of spiritual concerns to see whether they were a factor in the problem that was being dealt with. And if they were, whether referral to, say, a spiritual care provider would be appropriate. And perhaps one of the key messages in that article was about explaining really that inquiring whether a patient has a religious or a spiritual belief that might be helpful or causing them concern at that present time is neither threatening nor coercive. And that's just to kind of bring you back to the fact it's all got to be about the patient in the middle rather than any other agenda. So I'm just going to show you some fun times that we had to give you a little bit of an interval. So we actually took the lots of the students of dietetic students and other health professional students on field trips to the conference, European Conference in Religion, Spirituality and Health. And first of all, we went to Malta. So I'll leave that a minute. If any of you are here and you would like to spot yourself in that picture, you'll remember the great time we had there. And that's another picture of us in Malta, and this is just the dietetic students, I believe. And then we went to Poland, and we were all delighted to find that at the end of the road there was a beach. We weren't expecting that. We were expecting that in Malta, but not in Poland. And a few more pictures of everyone in Poland. And then we actually really put Coventry on the map for religion, spirituality and health, and had the conference here. And incidentally, this is the conference that I asked Richard in his third day of his job to introduce. So that's what the conference we had, and that's the delegates, and then the conference organisers as well. So back to some research then that I did during this time when I started to look more at integrating the spiritual side of things into care. So I published cross-sectional study in the Journal of Religion and Health on the findings really that in the UK, those affiliated to a religion and to Christianity in particular were more likely to be overweight than those who weren't affiliated to it. And this was something that couldn't be explained by the confounding factors such as smoking status. This was just a cross-sectional study, so obviously we can't suggest any causality. And the headlines surrounding it were actually quite tongue-in-cheek in the time. But what it did do was it gave a good evidence-based rationale for exploring the integration of Christian spirituality into weight management, and to do so in the UK, which hadn't been done before. So this led on to research developing Taste and See. And Taste and See is a church-based programme to develop a healthy relationship with food. And I'll explain a little bit more fully about that in a moment. But I first want to shout out to somebody else. So this work around Taste and See was all made possible with Ria and Ria's hard work. So Ria Patel, who is now Dr. Ria Patel, joined me to undertake her PhD at the time on this project. And so a massive thanks, Ria, to all your hard work then and now as well. And we conducted the first feasibility study in the UK exploring a religiously integrated weight management programme. And we found that it was both feasible to conduct this research in a church community, that volunteers could be trained up to facilitate its delivery, and that participants' health outcomes, particularly, I don't know how well you can see that, but particularly in the area of mental health, improved. And so you've got reduction in depression, anxiety, improvement in mental well-being, and some of the dietary related factors improved as well. So this was a mixed method study, and qualitative results were also important, and these showed that really previously God and food issues were separate and had been kept separate. But as people went through this program, they began to use faith as a resource, which is that indication of positive religious coping. They found that eating freely, which I'll talk about in a moment, was a challenge initially, but then they moved into feeling that that freedom actually gave them empowerment and enjoyment that they hadn't had for a long time. They also found that it was important to address weight in a holistic way, so addressing more than a weight problem, but all the biopsychosocial, spiritual side of things was really appreciated. And they also found that sometimes it was hard dealing with other people in the group, and that's often the way when groups are together. So this was just a feasibility study, and there was no control condition. So we moved on to conduct a cluster randomized control trial across churches in the UK, and the data collection for this, from the 2-year follow-up from this, is just completing now. So that will be coming out soon. So we haven't got that just at the moment, but you can look out for that one. Alongside developing Taste and See, I had another PhD student who is now Dr. Nazanin Castiganan, and she was exploring intuitive eating-based programs and comparing them to conventional weight loss support. And the ethos of this approach was about improving well-being first and then enabling weight control to follow more naturally. And so again, a very holistic approach to it. And although the quality of evidence wasn't particularly high at the time, it did suggest that this was a more compassionate and stable approach to weight management, and that it was this approach that contributed to the content of the Taste and See programme as well. So I will just tell you a little bit about the theory behind Taste and See. So at the centre, there is a kind of dieting weight gain cycle, which really needs to be broken, where people might put themselves on a very restricted diet that's difficult to sustain. Then they might not manage it and they feel guilty because they start eating again, and then they might just give up completely and eat more, and then they suddenly get to the point, well, actually I think I need to lose weight now, and they go back on the dietary restriction. So this kind of cycle can go round and round in people who particularly have a history of yo-yo dieting, and it can be all encompassing and really affect people's quality of life. And the intuitive eating principles, there are 4 principles to intuitive eating, and it kind of map those onto this cycle as the basis of our theory behind Taste and See. So where there was dietary restriction previously, we encouraged unconditional permission to eat. And then where things were difficult to sustain, we taught about eating in response to physiological hunger rather than emotional hunger. Where there's guilt and shame, it's around looking at self-acceptance and body appreciation. And then instead of the kind of feeling so bad that you have to give up and eat more, we focused on dealing with emotional eating. So that's the kind of intuitive eating aspects that we added to this cycle. But then what we did uniquely to address the spiritual side of this was because it was running Christian churches, we added a spiritual side from Christian spirituality. So here we looked at Christian principles of freedom, and here we looked at that freedom being with responsibility. And then where there was guilt and shame, we looked at love, forgiveness, and acceptance by God. And then where there was emotional needs, we looked at exploring spiritual needs that could be met by God. And I think what's important here is that, you know, there's not a focus on one thing or the other. It's integrated, and religiously integrated programs. I think it's important to remember it's not just, you know, that I'm not of the idea that you know, religion can perhaps fix something that in isolation. You know, I think it's all about incorporation and making sure that we are meeting individual needs. But I've probably laboured that point already. Anyway, the taste and see intervention has gone through many refinements over the years, and we had to make it accessible to many and suitable for the UK-wide trial. So we created a DVD and a manual for the programme, and all the filming and production was done with the help of many others, as you can see there, and also the support of my local church. Now, we then had churches asking to buy the product rather than be involved in the clinical trial. So we also made it available to purchase through our website, and it became a Cinnamon recognised project. So I'm just going to click on the website here. This is the website here, and it tells you all about it. And I'll just scroll down so that you can just see the trailer that we use where it's connected with the Cinnamon network.
There are a lot of people in our churches and communities whose lives are secretly ruled by food. They feel guilty whenever they eat or step on the scales, and they find themselves in a cycle of feeling unhappy, dieting and overeating. Now, churches have something unique to offer those struggling with issues related to food. They can provide a welcoming community where individuals are accepted and not judged. And Taste and See equips the church to support individuals in their own congregations, the local community, and even further afield. The programme provides expert advice and materials from Coventry University and gives participants a unique opportunity to explore how faith can help. There are several ways your church can run Taste and See. Volunteer facilitators can run the sessions in small face-to-face groups, or they can deliver the programme through an online community platform. The Taste and See pack and online resources contain all the materials you need to get started. You just need to add a facilitator, someone who is kind, good at listening, and can encourage discussion.
One of the things I found difficult at the beginning was the concept of bringing God and spirituality into my eating habit. However, as time went on, and especially having finished the course and I look back, I think what the spiritual side of it has done, having Bible studies about being made in the image of God and being beautifully and wonderfully made, it's helped me realise that food is one aspect of me and not the overriding aspect of me. And actually, God is interested in every aspect.
We have found that those who take part in Taste and See experience an improvement in mental and spiritual well-being. They emotionally eat less, benefit from an improved quality of life and a healthier diet. As they discover more about food and explore faith, they find freedom.
I'd just like to obviously thank Coventry University for investing in the programme through Pump Prime Research Funds and also Enterprise Awards for its ongoing development. You might have noticed there from the video that there's a variety of ways in which Taste and See can be run, and we've had to embrace the digital age in enabling this programme to take place online. Now, many others are much more tech savvy than I am, and I've been and have been running digital interventions for many years. And this side of things is perhaps an area where I am starting to develop further. But I'm pleased to say that Taste and See is now available through an interactive online platform, and it's being piloted in this new format. And this is thanks to someone else who I'll mention now, who is my wonderful colleague, Professor Andy Turner. So here is Andy. Now, Andy has been at Coventry University for many years. He is the creator of the HOPE programme and the H4C digital platform, which Taste and See now runs. And Andy's work focuses on the development and testing of positive psychology approaches to self-management, and he has a suite of digital programs for improving mental health in a variety of conditions. And one thing Andy probably doesn't know, actually, is that when I was considering taking up a post at Coventry, I looked into the research which was being conducted, and that's actually when I first came across the HOPE programme. And when I read about the compassionate focus of these programs, I was really keen to join Coventry and work where all this was happening. So Andy, you were right there at the beginning. And I think we met in our first few weeks at Coventry, and ever since then, Andy's been a supportive colleague, and we've supervised many PhD students together. And also he's been a quiet voice of encouragement to me as I've progressed in my career, becoming professor. And also as I moved away from leadership to those who were predominantly lecturing staff, to those who were predominantly research staff. So really this brings me to the last leg of my journey. And there are so many others who have worked with me on so many other projects. And there are many more PhD students who have gained and are gaining their doctorates. And I've not had time to tell you about all of these, but you can, look them up online and look out for new publications. But one last project I'll just mention before I finish is this project here. And RIBS stands for Religious Health Interventions in Behavioural Sciences. And I'll just click on the link to this and just give you a brief glimpse of the website. Hopefully that will come up. So Ria and I secured funding from the Templeton Foundation to categorise and define the religious components that have been used in health research studies and clinical practice up until now. And really this is quite groundbreaking in the field, and it's creating a shared language for religiously integrated healthcare interventions, so that that can be used in their development, delivery and evidence synthesis. So not long after becoming a professor in religious health interventions and dietetic practice, I then had the opportunity to focus on leading a wider research team and became professor and theme lead. So this is a behavioural and implementation science theme. And you can see there that it's quite a diverse theme that we were trying to pull together lots of the aspects of holistic care in order to provide for interventions. Yeah, I was just giving a shout out really to Richard there, who opened up the latter opportunities for me, and also to Karen, who is operations manager of the Centre of Intelligent Healthcare. And you can see she was just on the end of the phone to me there, helping me. And she's always there to tell me where I should be, what I should be doing and what I've forgotten. So that's really great. And then just the last bit then is just, I was going to play a little video about what CIH is all about. Can you hear it?
Revolutionary technology and practices are driving a healthier society, and there are now more people than ever living with long-term physical and mental health problems. As a result, healthcare is facing new challenges, including mounting expenses and a growing need for more cost-effective, smarter healthcare solutions. At the Research Centre for Intelligent Healthcare, We are tackling global health challenges by undertaking cutting-edge research in public health, including developing digital self-management tools and behavioural interventions, as well as creating wearable sensing technologies for the next generation of healthcare monitoring and management. Our growing team of multidisciplinary researchers focus development within 3 key themes: behaviour and implementation science, epidemiology and evidence-based healthcare, and healthcare technology and innovation. These 3 themes interlock to develop intelligent healthcare solutions for real-world problems. Our world-leading experts deliver research and development with global impact that inspires future generations and provides a timely opportunity for the UK to gain a leading position in AI, state-of-the-art sensing, and digital health research. We work with industry, charity, clinical partners, and policymakers, as well as user communities to ensure that our innovative research generates meaningful impact on society. Our postgraduate community is an integral part of our vibrant and thriving research environment, contributing to pioneering research and influencing change at the highest level. We are also inspiring global learners through our world-ranking publications, dissemination, and interactive online learning experiences. To find out more about our research, our postgraduate opportunities, or how we can develop intelligent solutions for your business, go to www.coventry.ac.uk/CIH.
I'll just say a final thank you on this slide, and then the thank you to my husband as well, who I've said is, you know, really the better man behind me as the woman. So that's all I had for you. I've just about kept to time. Sorry for the technical difficulties, but if there are anything anybody would like to chat about or ask any questions, then now's the time.
So the first question is, how do you see Taste and See beyond the Christianity in the church, particularly in the context of the UK City of Culture, Coventry being that at the moment?
Yeah, absolutely. So Taste and See is actually, although it's based on Christian principles, you don't have to be a Christian to go to it, and it's open to people of all faiths or none, although I appreciate not everybody might want to go to that. But we did have some people in the study who were from other faiths who found that it was helpful. But although that has been done from a Christian perspective, there's been a lot of research done in similar sort of studies in other religions and other areas of spirituality, and really, you know, it's there as an exemplar, and it can be something that can be taken and applied to different situations. Did that answer the question? I can't actually see anything right now.
Okay, so another difficult question for you. How do you distinguish between religion and spirituality, or are they synonymous?
Yeah, so I think religion and spirituality are quite different. I think spirituality is an all-encompassing term, and I think religion is perhaps not such a big term. And I tend to think that people, that the spiritual side of people is something that people might identify with, and they might not identify with it, or they might identify with it from a spiritual point of view, where they're looking at spiritual connection, maybe connection with nature, you know, just a kind of wider connectedness outside of themselves, and that's a kind of a non-religious spirituality. But there's also people find that meaning, might find that meaning from something that's not religious, but they also find that meaning in terms of a religious spirituality, and that's where they might be following something that's a little bit more sort of well-known path according to a particular religion, and usually in a religion there's a sort of a kind of holy book, and you know, a more institutionalized individualized approach. So I would say spirituality are different. I think spirituality encompasses both. And I think for some, people's spirituality is religious, and for other people, their spirituality is non-religious.
And another question, one of the interesting things about doing these inaugural lectures by Zoom and not being in a room altogether is that we get individuals, we have one here from Sri Lanka who's been listening in and saying, another question on that, how would this would apply to individuals with non-theistic faiths? Is there any literature that you could recommend?
Yeah, so there is a whole body of literature around Eastern religions and non-theistic faiths, absolutely. And it's, again, it's around, the application is really around, well, who is the person that you're trying to help? I think it's always got to come back to that, and it's got to come back to where are they at? Where are they at on a spiritual journey as well as their health journey? And then it's got to come from there, really, in terms of what's the right approach for that particular individual. So that's, yeah, I don't know if that answered that question.